So very good evening, Dr. Yatindra Dubey. A big round of applause for our guest faculty. And I welcome all of you, Dr. Yatindra Dubey, Dr. Ankur Bhavsa, Dr. Alok Prapanna, Dr. Udgit Thakre, and Dr. Revati Iyer, myself, Dr. Ritesh Shah. Now, rather than a workshop, now the first topic I was given as Smart ICU. Now, everyone is behind AI, artificial intelligence. I strongly feel that artificial, the name itself, comes in mind that if we don't think that AI should be covered, that the first thought process never origins from the artificial. It's always we have to use our mind, right? So AI gives you what? AI gives you data. This data, that data, and one point of time, lakhs and lakhs of data. But what is more important? Interpretation of the data. Still, people have progressed uh, up to certain extent that how to interpret the data, and ultimately it boils down to number, some number x, y, z. Most important is the intervention based on those data, and that definitely requires human brain. It cannot be just relied upon a technology based on kind of point X and point Y. It is not that simple. And as far as critically ill patients, we know that our body is complicated. The systems are complicated. The disease process is dynamic. The response is further dynamic, and the outcome is beyond us. That all of we know that our branch is effort based rather than outcome based. So the popular belief that smart means based on AI depending only on the data, as I already said, most important is interpretation and intervention. The word smart comes with a cost, definitely. Any technology that costs. The real smartest should be to think about the cost effectiveness with comparable or better results as far as care and outcome is concerned. It's not only outcome. Everything is based on outcome. Oh, if you use this, probably you can get better. Now, how many years that have been passed that any molecule, any drug, or any intervention, or any technology has improved mortality? Absolutely no. So we are going ahead with secondary outcomes, which is also equally important, like care. How is the bedside care? How can we decrease ICU length of stay, and so on and so forth? So the man behind the machine is important. It's a very popular sentence. I would say rather than only technology, the strategies should be smart, and one small part should be the technology. So whatever strategies that we adopt in ICU for day in day out function is more important rather than only based on technology. So who or what should be smart? Infrastructure, yes, it is required nowadays. If you walk in, you should have that feel that okay, this ICU is probably well equipped as far as equipments are also concerned. Equipment, of course, yes, required. Systems, definitely yes. Each and every ICU should be having systems protocols. But manpower, it's absolutely mandatory. So, manpower has to be smart, whatever you choose, infrastructure or equipment or systems or whatever. But the man behind the machine is more important rather than anything else. So question 1. Now I am going to throw a lot of questions to our panelists. I have made it panelist. So I got a lot of reason કે મને કીધું નહીં panel ક્યારે કરી નાખ્યું. So I want to discuss rather than uniform or unilateral lecture, unidirectional lecture, and I want that experience to be utilized. This is not evidence based only. Now experience is always evidence based, but experience makes you wiser. So, irrespective of, we know that a lot of designs and everything is infrastructure and everything is there. So, I would like to start with Dr. Yatindra that ICU design. Now, the stress upon that what I want, that what should be minimum requirement or smart requirement as far as ICU design is concerned. So, the strategy should start from ICU design rather than afterwards, that okay, one ICU is there, just let us make it AI equipped. No, right from that I want to make an ICU. So, Dr. Yatindra, you can. Mic, please. If your second mic, please give. Yeah, that's working. That's working.
I think the design wise, you have to just roughly they say your IC should be around 10 to 12% of the total bed occupancy. But before that, I think you should identify the area what you will be covering.
Little
Specialties,
louder, probably. Little louder.
I think it should be around 10 to 15% of the total beds what you will be covering. But before that, what specialties, what subspecialties you will be having, what are the group of consultants you will be having. At the same time, the drainage areas, the patients likely who are come to your ICU. Now, design-wise, roughly each bed area should be around 150 square feet minimum. There has to be partition between the two beds, preferably some partition so that the privacy is maintained. There should be place for doctors. There should be place for family. There should be place for counseling. There should be place for equipments, central monitoring. But I think you have to divide in the two, whether you have a corporate setup, and many of us, we work in a resource limited setting. So I think the resource limited setting, as you already said, it's the man behind and the result that counts. So if you have too many heads and you pay a lot of money for that, then it's a big issue. And uh, it should be preferably on the first floor, or it should be in the area where its diagnostic facilities are nearby, where you can maneuver the patient very easily, and somewhere your access to the emergency room is pretty easy, where you have to not cut the many corners. So these are the things what we should design it. But having said it, it's very easy to say, but in actual practice, when we have to design, we have to cut a lot of corners and we have to make the things cost effective.
Thank you. Dr. Ankur, any comments on instruments?
Before instrument,
Now, it's not equipment, it's instrument other than the electronics.
one more thing. We have seen in a lot many hospitals there are different ICU. Like for cardiac ICU, it's a different. Neuro ICU is different. So again, here what we can do is that we can have one larger ICU in which all the patients can come, because that can cut short the manpower and we can monitor more patients with same number of the staff. That is one more thing. We can have probably design wise also we can do a smart things in which we can small things like dialysis should be facility should be on all the beds, so we don't need to shift the patient to all the beds. Smaller things, I think this
Matter.
is, yeah.
So, with a lot of other questions, so I'll just cut short that ICU design. Whenever we want to make an ICU at that particular time, we should think that how can make my ICU smart rather than after making or leaving it to probably the architect, right? The architect will have will work on paper. Functionality point of view, we are the best judge as far as which, suppose it's as simple as that how a stool or urine would be transported from which pathway. So this, the first thing, like infection, right from infection control and privacy, as said, should be thought of. Now there are certain key facts. Now ICU design is a very big topic. We do have workshop for 4 hours only on ICU design. But most important is the visibility. Whether you are in resource limited setting or you are in very good big corporate setup, most important thing is visibility. Now partition can also be made in such a way that visibility can be expanded. Otherwise the corners cubicles are the sufferers. the farthest the ICU bed from the nursing station, they suffer the most. So we should have definite a good visibility from your eye. The place for cut, clean and dirty utility, as I already said, the central monitor should be replicated. Now everyone keeps central monitor on the nursing station. Tell me how many times you have seen nursing sitting at nursing station and still looking at the monitor. They go at nursing station only and only for some, ordering or some documentation or so and so forth. Nobody is looking after the central monitor which is placed at nursing station. It is required because it's a mandatory requirement, NABH point of view as well as the ICU design point of view, but we can definitely replicate. Keep one place where you can have a television, where the same thing can be replicated. So whenever during daytime we are all functional, nighttime yes, nurses sit down there. But during daytime, one place should be designed in such a way that only TV is there, where the central monitor can be replicated, which is very very good in picking up the silent alarms. I mean silent alarms. It's a opposite word, but silent alarm means that alarm is there but nobody gives attention to, and which results into disaster. Adjacent AV counseling room, audio visual. Nowadays we know that AV is absolutely mandatory. Least movements through the ICU door design should be such, right, that certain services should be inclusive within the ICU, certain services should be outside ICU with one door passage, like the door design. Door design should not be kind of touch or handle or something. It has to be sensor based as far as possible. In majority of the ICU it is very difficult, but this is how it should be. User friendly equipment rather than complicated equipment. Everything is, I got this equipment which is launched just last month. And you just, if you're working in ICU, take some time off and you ask your nurses, tell me all the functions of one simple monitor which is having 3 parameters or 5 parameters. It is very very difficult that we are using hardly. It is like our smartphone. I have a kind of iPhone. We use hardly 10% of it. The same thing monitor, we hardly use 10% of it, which is literally less. The monitors are really smart. We need to utilize optimally. For that, less complicated monitor should be there rather than more complicated. The curtain placement design, the additional rubber over the wheels, जो सो जेटली corners હશે ને ત્યાં આગળ ખાડા જશે. Whatever corners you see that because of the movement of the bed, stretcher and machines and so on and so forth, all corners are literally broken from the edge. So we should have certain rubber material which is commercially available to prevent that. Different electrical voltage distribution and so on and so forth. So design should be function based rather than structure based. Certain things are required like dirty utility, clean utility, the electrical power, the dialysis, the equipment station, charging station, everything is necessary. So put on paper and place in such a way that function can be smarter rather than having a big ICU and just show off. Believe me, that requires a lot of sitting with the architect, and you really need to spend time. Having said that, you need to start thinking that when patient enters, what should be the movement. Right from beginning, you can design your ICU. Let's go ahead. Nursing staff. Now it's one of the big challenge. I know there is no conclusion to it, but I would like to ask Dr. Alok, ANM, GNM, BSc, IDCCM, that is Indian Diploma in Critical Care Nursing, what should be the numbers, ratio or distribution of duties?
There are certain problems that with this NABH coming up, we require lots of nurses who are qualified. And I have seen personally, there are two types of nurses. One is qualified, GNM and ANM, etc., and others are experienced. They are trained in other institute of 6 months and 1 year, and after working in ICU for years together, they are, they are really excelled in their work. But the thing is that okay, they cannot be made either in charges or something like that. They have to be on an inferior position. And in real sense, most of the GNM staff which we have, they go to Bangalore for 15 days and get certificate for first year, second year, and third year, and our routine staff is most experienced. And then there is this dissatisfaction because the GNM staff, though less qualified, less experienced, they are getting more salary compared to those who are really working. So that is a problem. That is one. And secondly, once these GNM staff, when they come to us, we train them. And once they are trained, other newer ICUs opening in vicinity or in Baroda, they offer them 500 or 1000 rupees more in the salary and they just go away. Thirdly, those who are qualified and really well, they are getting good salary in the means they are selected in government job. And once this in government job, they are getting more salary and less work. So they leave. So again, we are facing shortage of good nursing staff. That is the problem which we are facing.
Any comment, Dr. Udgit?
So managing nursing staff in ICU is a really very challenging because the turnover is very high. So all the problems, as Dr. Alok sir has already seen, the solution to that might be that we can retain our staff as much as we can. But if we cannot, then we can have a post called nursing educator who may or may not be qualified. As sir said that he or she can be an experienced nursing staff but may or may not have qualification. If they have qualification, it is very good. But the educator's job is to maintain the culture of the ICU, the nursing culture of the ICU, where bundle care is properly maintained and the infection control measures are properly done. And that person's job is to train each and every new nurses that this is what we are supposed to do and this is we are not supposed to do. Including hand washing and talking to the patient's relative nursing care is a very, very important part of ICU care. It is as much as what doctors do. I think nurses does a little bit more work in ICU than what actually doctors do. And in a single duty, there are so many things like 200, 300 things which they are doing in bits and pieces. So error is also required to be prevented. At the same time, they has to be work comfortably in the ICU. They should not feel stressed out. Otherwise, they will do mistakes. So I think nursing educator is one thing which we can implement, and infection control nurse also is one important thing which can improve the ICU's outcome.
Yeah. So let us confess that we can't have GNM, BSc all the time. Majority are ANMs. More experience, as Dr. Alok has already said. But I would say that the hospital should encourage ANM to GNM while they are doing duty. Nowadays the distant courses are there. I think one of the solution to this is that sponsor them in such a way, have a bond for 6 months or 1 year, and it's not that costly to turn from ANM to GNM. You can always find out so that your NABH is taken care of, as well as there is always some reciprocation from the nursing side as far as the bond is concerned. Hierarchy should also depend on skills rather than only degree and experience. Yes, there has to be some incentive based on the experience as well as the skills. Now, right now, BSc fresher is getting the same or higher pay than the GNM of 5 years experience. So, and BSc nurse doesn't know anything, just fresh pass out like we MBBS. When we come out, when we do our first duty, we only know that how much we know, right? So any emergency comes, બહારથી બધા actor તરીકે કરી લે, મોટા ભાગે nurses જ કરે. So that's hardcore fact, right? So there has to be some incentive to skill and experience rather than only degree. In ICU, that's debatable 12 hours versus 8 hours just to prevent handover error. So functionality should be such a way that minimum ICU nurse should be changed during number of hours as compared to number of hours. So 8 hours, 6 hours, what we do right now, 6 hours, 6 hours and 12 hours. So there are 3 times there will be handover, and if you have 2 times handover, the errors can be minimized straight away by 33%. 1:1 is dream. Forget about 1:1. Helper system is really helpful that you can designate certain people like ANM or even not ANM to have kind of helper or some designation depending on your type of the hospital, which really works. So they are getting pay Like nursing salary is 5,000, but they get helper incentive maybe 3,000 rupees. So they come into category, okay, the BSc nurse is getting 10,000, the GNM or ANM is getting 5,000, but actually they are getting 8,000. So bifurcate in such a way that they can, and these are the people who to whom we can retain more rather than BSc nursing people. Nursing college is the answer. So if you have in-house nursing college, that's the future. But we know that there are a lot of stringent criteria since last 5 years, 6 years that they had made. It's very difficult to have nursing college, and nothing like IDCCM, that is Indian Diploma in Critical Care Nursing, that you make a system hierarchy as Dr. Udgit had commented, that have some programs, educational programs, that CNE, Continuous Nursing Educational Program. A nurse tutor post is more important. What we know that one is nursing, matron, assistant matron, the supervisor, nursing in charge, maybe second in charge or duty supervisor, and staff nurse, that is junior, intermediate, and senior. So this is the routine hierarchy where we need to penetrate a nursing educator in between, so that even if the turnover is there, the system should be maintained by the nursing educator rather than anything else. There are one or two people, so that it's not very heavy as far as expenditure is concerned. Let's go ahead. Same way, ICU registrars, medical officers, qualified intensivists, round the clock, MDs, MBBS, and alternative medicine. Dr. Revati.
Yeah, see, we've actually gone through these problems in our ICU. Before we started IDCCM, or there was a lot of, we had qualified people. We never had BHMS in ICUs. We always had anesthetists doing duties, afternoon, evening, nights, but still there was a lot of gaps. They used to come for 1 night or 2 nights, and there was no follow up. And all of them had their own ideas. They used to treat patients on their own bill, and we were not very happy with the quality of treatment. But since we started the educational, the IDCCM course, since we started having students, things have been so well protocolized. So these even post MBBS students who stay with us for 4 years, I'll tell you, actually they do a really very good job rather than the MDs who come to us for a 1 year IDCCM. Dr. Ritesh will agree to this, because we are like teaching them from the bud. We are making everything. By the end of the 4 years, they are really doing a good job. They become good flash intensivists, and we have a good night's sleep. They know the protocols. The patients are taken care of very well. So I think the qualified intensivist, and I don't know why ISCCM closed the post MBBS course. That's a big grudge we all have, because that's difficult now. But I think qualified, at least well trained intensivists are needed in to manage ICUs. They are even better than a qualified MD medicine or an anesthetist or a post MBBS without any experience.
Yeah, any comments, Dr. Yatindra?
I think I agree with what Dr. Revati said. But the problem is, as you said, most of the time they leave, they don't stick to you. And there are centers where there are no IDCCM courses. And I feel there has to be a combination of everything. Uh, Alternative medicine, these guys have a lot of drive and they want to do something great. If you have a three ladder where they come, they're just something like a helper, they learn. They go to second ladder and they go to third ladder. And by third ladder, they come to a level where they are very good in intubation, they are very good in ventilation, they are very good in helping in the lines. They become an asset, they stay with you for a long time. I think this is one thing which we cannot ignore. Now, those with MBBS without IDCCM intent, they don't stay with you for a long. They have an exam, PT, they leave you. Intensivist has to be there. One qualified intensivist has to be there every duty because he has to guide. And it has to be a combination. If you have a 10 or 12 bedded ICU, one intensivist is a must. I think we cannot do without it. That's there, and then you can make the combinations as per the cases what you usually do it. 4 months when you have a very busy ICU, then I think you need more. And there is a during slack season, maybe you cut down on that.
Yeah. So, no doubt about it that round the clock intensivist is the ideal scenario, but it's for larger and corporate ICU. It is not very easy to bear the cost as far as round the clock intensivist in house is concerned. As far as one in charge is there who is responsible for everything, makes difference, there is no doubt about it. Residents are ideal. IDCM residents nowadays we have a lot of critical care residencies, but not in all the hospitals. MBBS difficult to get trained people and most short-term population. They just leave in no time, and they are no better. Many a times, if they are in early years, they are no better than the alternative medicine chap who are having, as Dr. Yatindra rightly said, a drive to settle down, a drive to learn, and passionate. They are not like working 8 to 2. They will not think if there is 3 p.m. or 4 p.m. That's we have seen. They stay back as compared to other registrars. We just where they just do duty. और and the primary focus is कि मेरी ड्यूटी में कुछ नहीं होना चाहिए. So it's not that proper evaluation is concerned, but yes, we can have combo as compared to our ICU design. I mean, type of ICU, the setup of primary, tertiary, secondary or tertiary care ICU, the number of beds, the turnover of patients. But most important is that one leader, as far as intensivist, is definitely required to make the things smooth. The alternative medicine chaps, they really stay back with you for a very long term. Nobody lives, before 2 years, 3 years, 4 years, 5 years. But we must be aware that a lot of medical legal issues nowadays. So we cannot have independent. There has to be one duty of any person. There has to be some other person who is there in house, round the clock, who is at least MBBS and who is literally somewhat eligible or somewhat trained to take care of even communication. See, communication is the key. 90% of the things can be done smoothly if communication is proper. Even good communication can deal with thousands of crowd. There is no doubt about it. A good confident communication which is lacking because of the lack of trained manpower at that particular time. So have a combo of all these people depending on your ICU. Yes, you cannot have just alternative medicine chair. There is no doubt about it. The reason is very simple. Nowadays, medical legal sue, and now after this Nyaya Sanhita is very difficult. That there is a provision for jail if negligence is proved, and documentation, which is most important, is also lacking. I'll come to that. So paperless or with paper documentation.
Yeah, so I think we should gradually transit from paper to paperless. As we have seen in some of the ICU in Mumbai and probably now happening in Baroda also. I think Seven Hills was the first ICU which Anuj was doing paperless work where everything was documented bedside. All the beds have PC. They enter all the procedures, notes. Even Udgit was doing some kind of paperless work, putting notes from the home consultant. I think so. I think that will have more documentation. Of course, it will take a lot of time from paper to paperless, but I think it should be paperless gradually, definitely.
Dr. Udgit, your
Udgit can
comments.
say more.
Yeah.
So basically, I'm using paperless ICU since almost like March 2023. I lead Parul Sevashram Hospital's ICU, which is a 120 bedded ICU now, and the whole hospital, that is 750 bedded hospital, is paperless, as well as my own setup that is secure. We have the same paperless system. the advantages are countless. So one thing is you are saving on paper and the stationery cost is not there. The negative point of that you are dependent on the technology and internet is mandatory. If you lose internet connection, it's a problem. Or the system shut down, then it's a problem. But the benefit of the same is like significant. So you can see the patient's treatment sheet from anywhere. Like suppose I want to revisit and change a drug, I can go ahead and open it in my mobile and I can change the drug at the same time. That the paper on which I am writing, the same paper, the same paperless document, that is the on tablet, the same file can be seen by the medical officers and seen by the referral consultant and can be opened anywhere, even any part of the world. So that is a big advantage. The one better advantage, the one other advantage of paperless system is it allows you to record audio, video and photograph in the same patient's virtual file. So if the patient comes with breathlessness, you can have a 30-second video that the patient is having 40 saturations with this much of breathlessness and the pedal edema is this much at the time of admission, and at the time of discharge you can take a photograph or a small video and document that the pedal edema is decreased and now the patient is stable. So that advantage paper system will not give you any time. Slowly the banking system and other system, the way they have adapted almost paperless facilities, like banking is now on your mobile. No one need to go to the bank. Similarly, the paperless system in ICU will definitely help. But it comes with a responsibility to handle it properly. The software which you are using has to be proper, and because we are medico legally concerned and we have to preserve our documentation for a long period of time, it has to be robust to take care of the same. Otherwise, it won't work. So, if you are ready, then go for paperless system. Otherwise, it can be a problem. The software has to be proper.
So thank you, Dr. Udgit. So all the key facts that is been summarized, but most important thing is the inhibition to go ahead from paper to paperless. There are two things. Number one, that we were not tuned to while our training. We need to adapt the newer system. Second thing, that the biggest advantage that I see is that, whenever you fill up a form, there are certain fields are mandatory. There is some asterisks, red asterisks. So if you don't fill up, it won't accept. So same thing, paperless should be there, where the asterisks of documentation should be there. That without that documentation, it will not go ahead. It will not let you to go ahead. So documentation, that all of us, let us confess that we are poor in documentation. Whatever we do, probably hardly 5 or 10% we put on paper. We do a lot of things. Patient is on 2 vasopressors, but blood pressure is good, urine output is good. We write patient is stable. Now, where is the stability definition? Rather than that, this kind of paperless documentation, there, yes, the words are necessary to put down on paper, that is on virtual platform. It's very easy nowadays, robust systems are there to save for very long term, and we have to remove that inhibition, but yes, beware of medical legal issues. It comes with a lot of responsibility to handle. The transition, believe me, after COVID is not very difficult from paper to paperless. So literally, if you have not documented, means you have not done. So paperless system will be able to record whatever we have done, any intervention, whenever, but the attitude should be there and it will be preserved. So we have to have that asterisk that, okay, fill up if any intervention is done today. So automatically the safety will increase because of the mandatory documentation. I would say that's the biggest advantage, right? So let's go ahead. Protocols. Do you think preparing protocols is a smart move, Dr. Ankur? Quickly.
Definitely, protocols has to be there. Like, uh, uh, if even if you have more trained persons, but still there will be subjectivity in treating all the kind of complications or disease. So if you have protocols laid down everywhere, or maybe on the bed, or maybe in the PC, things will be definitely better. So majority of the things, we can have protocols, and it should be treated with the protocols only and only.
Dr. Alok, what about execution and monitoring? Protocols are there. Now it's available. We can make our own protocol. But the execution and monitor, what would you say that what should be the smartness in execution?
many times what happens that most of our residents, they are floating population. Means they come here till they prepare for some exam or something like that. So it becomes really difficult. We have protocols, but they say, "Okay, "Nahi, in that hospital we do like that." But they have to do what our protocol is. That is the problem. We might ask, and the problem is that there are lots of people who are doing various duties in other hospital and then they are coming to our hospital. So they mix with the protocols. That is the problem.
So it's easier said than as far as preparation is concerned. Difficult to implement or execute. It is there on paper, but the compliance is a real big challenge. And there is always some excuse for not following the protocol because of the nature of the critical illness. That this patient had this, so I did not follow. At that time, patient had like this. So the dynamicity is always an excuse for not following the protocols that we have to be literally stubborn to execute anything.
Yeah, so as we already see on the slide, the key for a better protocol management in the ICU, the execution part is that you involve the person who is supposed to follow the protocol to make the protocol. So I am dictating protocols in XYZ ICU is not going to work. I am dictating medical protocol in my ICU will work, but nursing protocol again the nurses has to make. So make a protocol. Those who are going to follow the protocol, the same team has to be involved in making the protocol.
So have ownership of the protocols. अगर किसी चीज को मैंने बनाया है तो मैं उसको ज्यादा इंपॉर्टेंस दूंगा आई मेक श्योर दैट इट हैपेंस तो दिस इज हाउ इट वर्क्स rather than just we thopify our protocols on nurses and believe me if you involve them you cannot think what the ideas they do have really this is my personal experience I have a lot of nursing protocols and majority that I had made with the help of the nurses who are really involved कि सर एक छोटा सा एक छोटी सी सिस्टर सजेशन देगी सर ऐसा करें तो and you literally it gets click oh this is very simple so it makes protocol simpler their point of view we as an kind of okay we are doctors and all we try to make actually protocol little bit complicated okay ये blood systolic 120 हुआ तो ये करेंगे 90 हुआ तो ये करेंगे ये करेंगे like mean 65 something like that make a protocol simpler that target one number rather than chasing four numbers it's so protocols should be simple and think about those people who are going to implement those or execute those so think in such a way that for them it is very easy to follow and it has to be layered layer 1 layer 2 layer 3 so sometime later we can discuss that now where do you think AI can help, Dr. Evdi?
AI can help at every level. So I think starting from like what Dr. Udgit had already said, like from starting from monitoring the daily ICUs to diagnostics to now robotics. So there is AI would help at every level. Only thing is how much we are involving it and how much it would take over. And probably tomorrow the manpower is going to be replaced by AI and we'll all be, jobless. So there could be some flaws, but I think that is the future.
Yeah, so basically, as per our medical profession is concerned, we are little less worried that AI or artificial intelligence or robotics will never be able to replace us as a human treating other humans. So it is little safer for us as compared to the other professions. It is safer for pilots and doctors, I feel. What in AI, the new development which come latest is like in critical care, you can make a digital twin of the patient. Like you receive a very critical patient, all the data you have like respiratory rate, pulse rate, cardiac output monitoring, etc., etc., etc. There is a digital twin. You can decide to treat the digital twin first. Like I want to give a fluid challenge to this patient. What happens if the artificial intelligence led digital twin stabilize after giving fluid, you will be more confident in treating your patient with fluid challenge rather than using vasopressor. So it is like that. It's an artificial software kind of a thing in which you can temporarily treat the data, not the patient, but the data, and you can see the outcome. So digital twin can be useful in some cases.
So yes, I would say it is more for simulation rather than anything. I will just give a simple example. Like, first of all, when I was given this topic, Smart ICU. Now, I had made it strategic Smart ICU. And I have compiled maybe 10 points, there are 100 points to discuss. Can AI compile those? Can AI think of that, okay, alternative medicine chap should be there, kind of, combo is there. We have to feed what we want. So usually from AI, what we want, we get back. For that, lot of data are fed. I'm not talking about just treating patients. Treating patient is one thing what we do. There are a lot of other things. The way the what about communication? Tell me. What about communication? Can AI communication? Suppose some robot is communicating to relatives regarding end of life care. Anyone will get convinced. Now, in all of us, we have done this, and we are doing very routinely that we call a most junior chap from the alternative medicine because of the relatives demand के sir ये मेरे family doctor है. We keep them in our the crucial decision making. So there are a lot of areas which were unexposed, unexplored, I would say. And AI, we have to, yes, it's positive that we get data. We get data ahead of the clinical science. That's what the distance, I would say, the most important is that patient को hypotension हुआ, उसके 15 मिनट पहले AI दिखाता है कि this patient is having perfusion related issues. So do something. Otherwise, 15 minutes later, you will get shock. So this is where AI can help as far as data is concerned. But anyway, we are using AI in one form or other. What is multi-para monitor? It is kind of AI in subtle form. The data is there, appropriate interpretation is essential, and most important is intervention based on that particular interpretation of the information is required, where the dynamicity can be only and only done or assessed in a right way by a human brain rather than anything else. If you give data to AI, they will have 5-point differentials. So ultimately, we have to use the percentage. Okay, 90% probably this patient is fluid responsive. What about 10%? And that 10% makes life here and there. There is always a thin line between life and death. So anyway, it's a big debate. I am a great fan of AI, so I am not against AI. But the thing is that we need to use it wisely. It also comes with responsibilities. We should not be dependent on AI. That is most important. Cost. Now we can have, probably fire discussion on cost. So Dr. Revti, what strategies would you like to execute to reduce the cost to the patient? Now, आपने ICU में कह है ना कि भाई kind of if 2 lakh bill is in 2 days, any patient is good, doctor ने लूटी ली दो. And if patient doesn't survive, तो पैसा ही गया and मानस ही गया. So we lose both the ends. This is very, very common nowadays. So we all the time we have to do strategies in such a way to reduce the cost.
Practically in a patient, especially in a patient who's a cash patient, who doesn't have a TPA payment or a corporate payment, invariably the first concern when the patient comes to ICU is what would be the cost. The question the relatives ask is what would be the cost, and then the further treatment and other decisions are taken. So generally over this 30 years of my ICU practice, my concern has always been to try to give the best treatment to the patient with minimal cost. So how to reduce the cost? Yes, what I normally do is try to do the minimum investigations which are basically required, not prescribe an array of 100 investigations on day one, go step by step, and then probably try to use a good brand of an antibiotic which is relatively cheaper, which becomes a little difficult for us also in a corporate setup nowadays, but we try to manage that if possible. And even radiology and cross references, we do as much as needed. in this cost cutting, there is always a risk of, sort of not doing certain things, getting in trouble, medical legal issues. So there always had to be a balance between cost cutting and doing adequate enough to cover everything so that tomorrow you should not get in trouble. The same relatives who were asking for reducing cost might come and tell you ki we never told you not to get a neurophysician's opinion or not to get an MRI. So it is a very delicate balance. But yes, this is what we try to do.
Dr. Yatindra, any comments on that?
I think you have covered everything. The only thing is the transparency. When the patient comes, even if he's a insurance patient and he's just 3 lakhs, and a corporate just goes away in 3 days or 4 days. So the moment you start treating this patient, after 3 or 4 days, he will be shifted to some other center. So somewhere down the lane, I think transparency should be very clear about that. The major, again I said, treating with keeping in mind in the resource limited setting. And if it is possible, to give the option to this patient, these are going to be the cost, and if you have these issues, you can go to the other place where the cost will be less. And I think this is the only solution what we can have. Whatever the antibiotics and whatever the investigation, whatever the things cross-references you cut down, there is always some bill and there is always going to be overflow. So the only thing which helps you is the communication, and right on day one, like I have my own setup, so I have a liberty of telling them on day one, you have a choice. So this is going to be the cost, and if you want, you can go to the any other setup where the things will be less. I think this has to be very clear.
So agreed, I think all points valid, that always evaluate what is costing more for that particular patient depending on the type of patients, right? Control of the pharmacy is the key, because if you see in critically ill patient, as high as 45% of the cost is from pharmacy. And if you see the list, if you see the bill, final bill, I think 10-page bill, 8 pages will be of pharmacy, because every small piece goes through the pharmacy. Choose the molecule wisely, as Dr. Ritesh said, that we have a lot of generics, but standard generics. I would say that standard generics, not research generics. Less is more as far as pathology and everything else is concerned. Minimum drugs on the board. Now evaluate your own treatment sheet, that how many drugs are on there. I mean, they are there on board. Simple things that I had, just jotted down. No offense, but think 10 times before using ondansetron. There is one huge lecture that I had given long back, and not less than 20 times I had given that lecture, misuse and overuse drugs in ICU. And this is the list. IV fluids is the commonest drug. Yes, IV fluid is a drug. IV fluid is the commonest misused and overused drug in ICU. Oxygen, nebulization. Now, post-operatively, all patients are, kind of nebulization, bronchodilators. There is absolute no need. Absolute, rather it is more harmful. Perioperative, you are increasing sympathetic drive. Oxygen. Why oxygen? Nowadays, even American Heart Association and American Society of Cardiology also say that in acute MI also you don't need oxygen if saturation is more or equal to 94%. You don't need oxygen because adding oxygen will not improve mortality. Yes, we don't know what is happening at microcirculatory level as far as oxygen injury is concerned. 1 gram paracetamol, no offense to any pharma, but 1 gram paracetamol has replaced the routine excellent analgesics even in CVTS surgeries with sternotomy. Now it is very, very difficult. You see that patient flips the heart rate to 80, 90, 100 where the beta blocker is added. So one way is beta blocker added, and other way patient is in severe pain. You have to use good analgesics, and 1 gram paracetamol is very, very mild analgesic as far as the major surgeries are concerned. Dressing material. We don't see how many disposables are used, how many dressing materials are used, Gamgees and gauze pieces. And you should have even protocol for dressing, that one gauze piece bundle should suffice for that particular dressing, right? So these small protocols and make a smart move towards decreasing cost, and you will be amazed that if you audit, I'll come to that, this is the last audit is the last question, but if you go back that what has costed more to that particular patient, probably for next few patients, you can really decrease the cost by not less than 10 to 20%, which is a huge amount. Yes, having option of good quality care ICU with relatively less cost, we should always give on day one rather than after exhausting 2 lakh rupees in 3-4 days in corporate hospital, and they are having 2 lakh budget that is being utilized, and there is no further budget in going to other hospitals. So lot of strategies as far as to reduce the cost is concerned we can implement. Now we have 10 minutes, we'll just go quicker. What smart strategies would you apply to prevent or reduce medical legal issues, Dr. Ankur? Quick words.
I think documentation, whatever we do, we see the patient and document everything, counseled well, audiovisual counseling is very important. Even if you do any procedure, consent, not only the blind consent, but informed consent, in the sense that patient is explained about the procedure. Nowadays we have good forms out which have everything like what is this process done for, what are the advantage, what are the disadvantage, what are the alternatives. All this is mentioned in the consent form. I think these are the main things, including documentation, counseling, audiovisual.
So what saves you is only documentation, documentation and documentation. It's the first principle of GCP, good clinical practice, that if you have not documented, means you have not done. Even if you have done lot of efforts, maybe for 2 days, 3 days, day and night, does not matter if you don't translate that into paper, onto paper. So audit of the documentation is always required. Have a random checking. Have a habit that once in a week you spend 2 hours and checking the files of your patients who are discharged or who are still there. Just do random checking. You will see, rather not surprised, you will shock. You will get shocked, lot of shock that क्या लिखा है ये, right? So even discharge summary. If you see discharge summary, which is the only representing document of the hospital, should be smart. And I have a compilation of lot of hospitals discharge summary where it is written cause of death is this, time of death, date of death is this, and down the line follow up after 7 days. And I am not joking. You go back to the discharge summaries. You spend 2 hours in a month to go through the discharge summaries of the hospitals that from your own ICU, right? Don't be dependent on others, because medical legal issue एक ही बार होता है, and that's done, right? Signature, we are not having any habit of having our own signature in all documents. All forms should be filled up with all the information, no empty box. If you see consent paper, patient का नाम लिखा होगा और नीचे relative की sign, बीच में कुछ भी नहीं. Arterial line कहाँ की, right है, left है, radial है, femoral है. Only arterial line will not suffice. Believe me, it will not suffice. You need to write down left femoral artery. And if you cannot get it done, then go back and document that consent was taken for left femoral artery, but because of the access issues, I had taken right femoral. That kind of minor documentation is also required. I know it is difficult, but it is nowadays mandatory. No medicine in black. That is, one of the most dangerous thing that ever happens. And cross verification. Me and one of my friend, Dr. Anuj Clark from Surat, we have innovated one module called Error Prevention in Critical Care. We have done almost 22 workshops on that. It is adopted by our national body also, and now it is we are converting into book, and it is patented because it's the first time ever in the world we have worked on errors in ICU, and we have innovated a module in such a way that it looks very fancy of our own Indianized touch, and we have named certain errors, so that you can remember. It's very easy to remember. So even after 5 years of work, what we did, that Dr. Anuj has visited my ICU and I had visited his ICU, and we have spotted almost 10 errors in one day. So this is how the cross verification literally helps, that okay, to provide further better care and be better, probably this is what cross verification or cross audit is required. And honest communication is the key. Whatever happens, if pneumothorax has occurred because of central line, it is a known complication. Go ahead and say, right? Most important is that whether you have tackled that pneumothorax is more important. So teleconsultation counseling, I think we have almost AI teleconsultation is now adopted or accepted after COVID. So I won't go into detail. This is the last question, audit. What strategies would you like to better evaluate the systems or protocols? Say execution, monitoring, as I said, but audit is important. As I said, that cross verification. We can start with Dr. Yatindra. This is important, so I'll just stress upon a little bit more time.
I think audit of everything. It goes right from bed sore, infection, hand hygiene, and uh, ventricular associated pneumonias, infection control practices, and morbidity over years. I think all this thing has to be audited and it has to be gradually followed up over a period of years how you have improved. And I think the only way you can do it is informing the parties what has been done and what should be done. And there has to be some encouragement rather than punishment for doing that.
Yeah. Dr. Ankur, quick comments.
I think the hospital who are doing NIBH, we are doing auditing, but we are doing, means it should be done in real sense, like what is our rate of VAP, what is the rate of our COTI, and similarly as he has, and NIBH also mentioned that we should not punish them, we can explain them how to improve whatever hand hygiene matters, how to decrease the rate of infection, and auditing of the doctors doing hand hygiene means everything should be done. Yeah, I think, yeah.
Dr. Alok.
In addition to that, I stress more on the auditing the documentation. That is the main thing.
Yeah, Dr. Udgit.
The document, the audit has to be displayed, and it is the like mirror of what you work. The all the ICU team has to work towards getting a better audited report in on your pinning board that our VAP rate is decreasing over the period of time. Our infection control strategies are getting better, and our mortality and morbidity ultimately is now better.
Dr. Revati.
Yeah, so audit is the practice of today. We have to audit to improve ourselves, and that has helped us over the period of time. And our nursing staff, our doctors, everything like CPR, quality indicators, infection modules, or the and it is a period like this was the data a month back, a year back, and now where are you? So that's how you know your progress or your regress, and that is very important. If it isn't done, then you don't stand anyway. So I think it's mandatory.
So audit actually is a mirror that what we have done, and it is not very pleasant to see many a times, right? But we must see to have better outcomes, better bedside quality, better care, and so and so forth. So it is a key, right from infection control, the quality indicators, as already they have mentioned, compliance of the protocols. Now this is one thing which is most important. We have our own protocols. We have implemented, we have executed, we have monitored, but we need to audit it to make those protocols better. So the whole, it's like feedback loop. Audit is what? Audit is to complete the feedback loop so as to understand where are the lacunae or do I need to improve my protocol. That this is probably troubling. So rather than that, we stress upon that particular factor more rather than having just general meeting again and again. So have the key module in such a way so that you can stress upon to do things which we are weaker rather than suppose if you are strong in certain things and if you are weak, definitely we must know that where we are weak and only audit can tell you. So we can focus more energy towards the weaker point rather than having our focusing more on our stronger points. So as I said, error prevention tools and error reporting systems. So have a culture of what is the wrong thing rather than who is wrong. If you make any nurse कि ओके तूने ये किया काम खत्म वो नेक्स्ट टाइम होगा तो सही बट वो छुपाएगी. So any person who reports error, we should have appreciation programs. Medication error is the most important and deadly error, where almost 70% of the time happens in any random patient, any day, right? 70%, as if you take one patient, 70% of chance if that patient stays in ICU for more than 5 days. So most important is having discussion of errors, spend 1 hour in 1 month or whatever, have incident reporting system that all of us we have. It is not that NABH, what NABH requires, it is our requirement. So it is like, wearing a helmet. The same thing I tell, that wearing a helmet is not for the police person, it is for us. So NABH is same. NABH is not for NABH or systems, NABH is for us. So I think the time is over. We can keep on discussing as far as the strategies are concerned, but maybe some other time. I thank all my panelists, Dr. Yatindra, Dr. Ankur, Dr. Alok, Dr. Udgir and Dr. Revati. And I'm happy that, I'm not seeing this at least this time. Thank you.